Our first speaker is going to be Dr. Ashley Ross from Johns Hopkins Medical Institutions. He completed his medical education and postgraduate trainings at Johns Hopkins University, where he is currently an assistant professor of urology at the Sidney Kimmel Cancer Center. Dr. Ross.
Thank you, Dr. Keeler, Mr. Tatar, and guests. Thank you for having me. As a urologist, we mainly deal with the diagnosis and management of localized prostate cancer, and I'm going to talk a little bit about the challenges in that area of the disease and some of the new both technologies and biotechnologies that may be paving the way towards the path forward. As a disclaimer, I guess two disclaimers. One is I run an active lab and do translational research, and I work with a lot of the biotechnology companies that are bringing these tests to market. And as a second disclaimer, new does not always mean better, and I'll give you my thoughts on some of the new tests that have come out and where I think they stand to advance or not move the field. So getting into it, so the challenges in prostate cancer, I think, can be summarized in this slide. One, it has a very high prevalence. About 1 in 6 men are diagnosed during their lifetime, and there are over 200,000 cases diagnosed this year. And easily, I would say everyone in the room knows someone in their family who has prostate cancer or has had it. Second, the disease represents a spectrum. On one end, there's some disease that's clinically insignificant or indolent. Men who have treatment for that disease probably have over-treatment, and it's estimated that about 50% of newly diagnosed cases don't need immediate treatment, and in fact might not even need treatment ever because of the long natural history of the disease. On the other hand, prostate cancer is a lethal disease. It kills 1 out of every 36 American men and causes 30,000 deaths per year, and so there's a dichotomy there. And so whenever we're faced with these challenges, it's good to look at, well, what do we know and what have we learned, particularly over the last several decades? First, like I said, it's a disease spectrum. Some prostate cancer is aggressive. Some of it seems to be clinically indolent. We can help ourselves define which is which when we have the pathology in front of us. It's harder to know before we have that. And second, in the recent past, we've been able to look at some of the molecular mechanisms that drive prostate cancer in a localized state to become more aggressive. So if we define clinically significant prostate cancer as disease that can spread and metastasize through the body, then maybe the best indicator of what that is the Gleason grade. So the Gleason grade was developed by pathologist Dr. Gleason, looking at prostate cancer under low power, and he was looking at the architecture of the glands. For the glands that basically looked almost like normal or were well differentiated, they had low Gleason grades. And now, actually, we don't even recognize Gleason grades of 1 or 2 as abnormal on a biopsy. It's 3 is the lowest score you can get. For those cancers that had started to lose contact inhibition and started to kind of clump together, they were patterns 4, and when they were single cells, patterns 5. And these cancers looked less differentiated. It looked like the cells could be happy anywhere in the body, not just in the prostate. And it turns out over time that we found that these Gleason pattern 4 and 5 cancers, and then they're reported as sums, so sums above 7, have a much worse prognosis than Gleason 6 disease. And so we know how we can attack the problem of who needs to be treated, who doesn't need to be treated, figure out who has the high-grade disease in their prostate. But one challenge is right now there's no imaging test, blood or urine test that can really identify that high-grade disease, although we're making some progress. So just to drive that home, if we look at men that were treated for prostate cancer, on the left, these Kaplan-Meier curves, so these men had their prostates out, but these are about 25,000 men treated at Johns Hopkins Hospital getting their prostates out. When we look at the people with Gleason 6 disease, this green line, basically with follow-up of almost 15 plus years, no one has metastatic or cancer events. So everyone does great. And when you start having pattern 4 or 5 disease giving you sums of Gleason 7 or 8 to 10, the survival is much less. If you look at on the right here, this is a nomogram based on data from multiple institutions about what determines if a man's going to do well or die of prostate cancer after local treatment. The number one thing that determines that is that primary Gleason score, and the number 2 thing is probably the secondary Gleason score. So that Gleason grade is really a critical factor. On the flip side of it, we say that we know to be aggressive, you have to have, you have higher Gleason disease, and that's in the presence of treatment. How about on people who haven't been treated at all? Well, our knowledge from that comes from a Scandinavian randomized control trial. And that trial essentially took men and randomized them to get either treatment by radical prostatectomy or nothing until they had metastasis when they were diagnosed with prostate cancer. And this was in the pre-PSA era. And what you see is for these low-risk men that had Gleason 6 disease, you see two things. These guys had prostatectomies. These guys had nothing until they had metastasis. And if you look at around 10 years, the dark bars here is the people who die of prostate cancer. The white bars here are people who die of other causes. At 10 years, there's no difference whether you had local treatment or not. So we know that people with life expectancies that are short probably are not going to benefit from local treatment to their prostate cancer. This is level 1 evidence showing that. The second thing you see is that if you take it out to 15 years, or 20 years rather, you can see some increase in the deaths of people who didn't have prostatectomies, but by and large, most people are dying from other causes. And again, that's for low-risk disease, and that's because the metastatic potential of that low-risk disease is low. And that's actually prompted us to know that we can probably do surveillance safely for low-risk disease. And in fact, with contemporary data in the PSA screening era, it's estimated that if a man chooses surveillance for low-risk disease up front instead of surgery, that they will die on average 2 months earlier from their prostate cancer, but they'll gain about 6.5 years of not needing treatment. So that's sort of what we have known, and over the last decade, we've gotten more into the molecular level of how we understand what aggressive localized prostate cancer is. And that's because we've been able to take small amounts of tissue and figure out what's the DNA look like, what's the RNA look like, what does the protein levels look like, et cetera. And what we can see is that prostate cancer, as opposed to some other cancers, has the hallmarks of enormous genomic complexity, not just point mutations, but a lot of chromosomal loss and gain and rearrangements. And Garraway's lab kind of looked at this extensively recently, and as you have localized prostate cancer, there can be all these different events that happen early on, but they do seem to funnel into one point, which I think is a key gene for localized prostate cancer, which is called PTEN. PTEN is a tumor suppressor. It normally is suppressing the PI3 kinase AKT pathway and keeping that pathway from causing cell growth, proliferation, and motility. If we look at it, that pathway, that PI3 kinase AKT pathway that's inhibited by PTEN, is actually altered in about 50% of localized prostate cancer, and it's the 50% that tends to be aggressive, and in 100% of metastatic prostate cancer. If we look on the right of people who've had prostatectomy and ask, well, what is the features in their pathologic specimen that will tell us if they're going to have the worst outcomes, the only independent predictors that could be found at the DNA level were the loss of PTEN or the gain of MYC that gave them a 7-fold higher hazard ratio of death. And indeed, in animal models, if we look at a mouse model where you take PTEN away so that you make them lose it early, they will develop aggressive localized prostate cancer, and that mouse just needs one more hit, whether it be an alteration in the TGF pathway with SMAD loss or whether it be a gain of this MYC oncogene, and then that mouse will develop metastatic disease. So that's a fulcrum point, and we'll remember it for later in our talk, and I think it's something we really learned about prostate cancer molecularly in the last decade. So let's go back to our challenges. So our challenges with prostate cancer, at least from the urologic perspective, is overdiagnosis and overtreatment. These guys with indolent disease, we wish we never found them because we may subject them to harm to treat disease that wouldn't kill them. So how do we have solutions for that? One is, let's try to we have imperfect screening right now with PSA. Let's try to make that screening as perfect as possible because PSA is not a perfect test. Our second way to meeting that challenge is let's develop a test that's better than PSA, that can find prostate cancer that's aggressive specifically, and at least find prostate cancer specifically. And if we diagnose you, let's make sure, maybe with these new tests, that you actually do need treatment or can defer it. How can we deal with treatment-associated morbidity, which is also a problem with localized disease, incontinence, impotence, et cetera? Maybe we can have better techniques for local therapy, and we'll talk about that a little bit in this talk, and they're going to talk about proton therapy later. And then how about undertreatment? What about these 1 in 36 men that are dying of prostate cancer every day? Well, the challenges there are the same as overtreatment. We want a test that identifies them at an early stage where we can cure them, and new drug discovery is also important. We'll hear about that later today as well. So let's go through the first one of overdiagnosis and overtreatment. And again, these are the two strategies. What's the best evidence we have for how to screen now so we don't over-screen and overdiagnose people? And how do we develop superior tests? So this may be review for everyone, but I think it's important to know where we came from with PSA screening. So PSA is the most widely used biomarker for the diagnosis and follow-up of any cancer. It's part of the human kallikrein gene family, and it's a secreted protein that probably helps to liquefy or modulate the semen. It's an antigen-responsive gene, and it's easily measured by an ELISA test in the serum, in your blood. It's not prostate cancer specific, of course. It just goes up with any disruption to the normal prostate architecture, whether that be prostate cancer or benign prostatic enlargement or prostatitis and inflammation. It was originally discovered from work to figure out what makes a prostate, and also for forensic work. And then it was assessed in the serum in 1980. And then Dr. Stamey, who's pictured down here at Stanford, had some seminal studies where he showed that the level of PSA correlated with how much cancer was in a man's body, and that you could use PSA for follow-up after treatment, where, for example, after a prostatectomy, the PSA should go to undetectable if the disease was truly localized. And actually, that's how PSA was first approved. In 1986, the FDA approved PSA for monitoring after treatment of prostate cancer. In 94, it approved it as a diagnostic marker to prompt a biopsy. And what happened once PSA was approved? Well, not surprisingly, we saw an 83% increase in the amount of prostate cancer that was diagnosed. The cancer that was getting diagnosed was diagnosed at an earlier stage in 1988, and there's some lead time bias here, but about 40% of the guys that had their PSA checked had metastatic disease. In 2010, it was about 4% of guys had metastatic disease. So it was more localized prostate cancer being identified, and because it was treated, there was a mortality decline, about a 40% mortality decline from the PSA era started to about the present day era. And the NCI says that about 70% of that decline came from PSA screening. So why is there this big controversy? Why does the U.S. Preventive Task Force say don't do PSA screening? Why does Barry here in this review in the New England Journal say this is the controversy that refuses to die? Again, it's because it's easy to detect low-grade prostate cancers that probably don't need treatment. And actually the ease of detecting it with PSA screening approaches that of autopsy prevalence. There was a tendency, although it's changing, to treat virtually everyone who gets diagnosed with prostate cancer. That's changing now. And there's morbidity, both of the diagnostic procedure, the biopsy, and also of the treatment procedures, surgery and radiation. And all of this has a financial and psychological cost and a health cost to the patient. So what is our best evidence about should we be doing PSA screening or not? It comes from this trial, which is actually the only randomized controlled trial that really looks at PSA screening versus not screening, and it was done in Europe, about 200,000 men. And this population, which was the European population, was not heavily pre-screened, so PSA testing was not common in these areas. They actually screened every 4 years, except for in Sweden where they did it every 2 years, and they would recommend biopsy at a trigger point of around 2.5 in most countries, some places 3 for the PSA. And what they found is in their core group of men, which aged from 55 to 69, there was a 20% reduction in mortality from prostate cancer. If they adjusted for people who actually followed the screening protocol, it was about a 30% reduction in deaths from prostate cancer at 11 years. If they took that out farther and looked at not just the median, but everyone who had made it to the 12-year mark, then the number of people who needed to screen was even less to prevent deaths. But the numbers generally are about 1,000 men need to be screened to prevent 1 death at 11 years. 37 men need to be treated to prevent 1 death at 11 years. And if you look out further at like a 20-year time point, which is where we usually are looking out for people with prostate cancer, then those numbers may decrease to needing to screen about 300 men and treat somewhere between maybe 5 men and 10 men to really save 1 life. So PSA screening does work. But what we learned from these trials and the data I presented previously kind of helped shape what the AUA's, the American Urological Association's recommendations are on PSA screening. And I think these are some of the best evidence-based guidelines for PSA screening. 1, don't screen men under 40. The prevalence of prostate cancer is very low. The prevalence of lethal prostate cancer is very low. And the chance that you're going to miss those men is very low if you start screening at 40. So don't screen at that age. For screening of men ages 40 to 54, we don't have level 1 evidence in that population, and so we don't recommend routine screening in that population. However, it can be considered on an individualized basis. If there's a family history of prostate cancer, if the man has higher risk, for example, due to being African American, then you can counsel him that way. For men that are in the core group of the trial I just showed, 55 to 69, consider routine PSA screening. The U.S. conducted another randomized trial of PSA screening, which was intensive screening every year versus routine screening, which happened to be in their control population every other year. That was a PLCO trial. And it looked like there was no difference between screening every year and on average every other year. So every 2 years might be okay, which has been even an adjustment for me in my clinic because I was so used to every year. When a man has short life expectancy, like we saw in the figure before, less than 10 years, they're unlikely to benefit from local treatment. So don't do routine screening in men with 10 to 15-year life expectancies. And as a corollary to that, consider discontinuation of screening at 70, although now I'd say that the population is in some ways getting healthier and living longer, so that's the one that I'm most uncomfortable with. But the main thing is, the reason we have these controversies of PSA is it's not a good test. And so can we find a test that at least is specific for prostate cancer itself or doing a little bit better to identify prostate cancer, if not clinically significant prostate cancer? I think that there is a little bit of headway made in that. There's a new FDA-approved test called the Prostate Health Index. It was approved, I think, last year, and it hasn't become really available for ordering yet, but we're starting to have it available in a couple months at Hopkins, and I think it's going to disseminate throughout the country in the next year or so, where it'll be easily orderable by physicians, and we'll talk about this in a second, but it was FDA-approved for PSAs, for screening for prostate cancer in men with PSAs between 4 and 10. And there's a PCA3 test, which is a urine test that is more specific for prostate cancer, hasn't really been utilized as much because of the high cost of it, and we'll talk about that as well. But that was approved for if a man had PSA screening and a negative biopsy and you're considering a second biopsy. So the Prostate Health Index is a blood test. It's based on the PSA and also other forms of the PSA that seem to correlate more with prostate cancer, specifically this -2 Pro-PSA isoform, which is a cleavage product of PSA. But it also incorporates the free PSA as well, and we've known that prostate cancer tends to make less free PSA. And this is a cheap test. It's an ELISA-based test. It costs about 3 times as much as a PSA test, and it's been shown to be cost-effective. And if you look at large trials from the US or from Europe involving thousands of men, these are receiver operating curves. As the area under the curve increases, it means that the test has more specificity, more specifically identify prostate cancer over this wide range of sensitivities. And PHI is way out here with this big area under the curve, and PSA is kind of like a 50-50 thing. And that's true in both of these populations. So PHI, this Prostate Health Index, in my opinion, is definitely a better test, and I bet it will become a way of doing primary screening in the US in the next couple of years as Beckman makes it more available to us. PCA3 is a urine-based test done after prostatic massage. The FDA approved it in 2012 for decision-making after the first biopsy. But there have been tests that show similar results to the Prostate Health Index, that PCA3 test can improve the specificity for prostate cancer over multiple levels. They were not sure from these tests if it really will change clinical outcomes, but it does look like this is also a better screening test. PCA3 has been around for a little while. Why hasn't it been used? I think the price point was astronomical. It was like $3,000 for that test, and it didn't get adopted for that reason. And it required a digital rectal exam, and only a few labs really incorporated it, but it is a better test as well. So in terms of once you're diagnosed with prostate cancer, how can we help a man decide on treatment or not? Right now, what we do is we risk stratify people based on a few characteristics: their rectal exam to stage them, their Gleason score on the biopsy, and their PSA levels. And we basically, even though there's very complex nomograms that are helpful, we sort of categorize them as very low risk, intermediate risk, and high risk. Men that are intermediate and high risk, that have Gleason 7 and above disease, most of us feel like those men need treatment. We know if we just watch them over time at 10 years, over a quarter of them will be metastatic, if not even higher than that, and so we feel that these men need treatment. But how about for low risk and very low risk disease? As we said, active surveillance is gaining acceptance, but it's still a little bit underutilized. Why is it underutilized? Some of it is patient and provider anxiety. And again, that's active surveillance is the idea of watching the prostate cancer by serial biopsies. When it becomes Gleason 7 disease or the PSA becomes over 10, then thinking about treatment. So part of it is the anxiety of watching this cancer because it can be unpredictable. Maybe you can be uncurable at the next interval of surveillance. And some of that is justified because, like we said, there's no imaging test, blood test, or urine test that can really tell you if you have aggressive disease in your prostate without taking you have to take the prostate out to know that. And when we do take the prostate out and take a look, about a third of men have Gleason 7 or above disease in the prostate, even if their biopsies said they had Gleason 6 disease. Also, there's limited data in younger men. So in older men, it's probably safe. Here again is data from that watchful waiting versus proctectomy trial. These are men that are over 65, treatment or not treatment, and there's not much difference in metastasis or death from prostate cancer in these older men. But in these younger men, there is a separation of these curves. Local therapy does help, and without data on surveillance of those men, do you want to deny them an opportunity for cure? And so there's trepidation there. So there's new molecular tests that are really emerging to help us with the decision-making of what do we do with our man who has low-risk prostate cancer, but we're worried about putting them on surveillance or not. And there's a few, none of these are FDA approved, but there's a few that have been developed in that area. Some of them have already come to market, and you can order them. They're CLIA certified tests, meaning that they're reproducible in the lab. There's a Prolaris test by Myriad. We'll talk about that briefly. And Ki67 staining. These are ways of looking at the cancer molecularly to ask how fast are these cells dividing? Because maybe the faster the cells divide, that represents aggressiveness. And there's things that look at biological drivers of the disease. The PTEN Immunohistochemistry, we talked about PTEN before, and the Oncotype DX prostate test by Genomic Health. And there's a newer test coming out too called ProMark, which looks at clusters of genes that might predict this. So let's look at cell cycle. Can cell cycle, how fast the cells appear to be dividing, tell us about is the cancer going to be aggressive or not? Intuitively, you'd say yes. This basically is a test where they do a quantitative RT-PCR to basically tell them what is the cell cycle proliferation score of the cancer. And this is data. It's called a cumulative incidence plot. This is time, and this is the development of death from prostate cancer. So having a graph like this is bad, and this is okay. And this looked at a population in Europe that was not treated. They were diagnosed with prostate cancer, not treated at all until they had metastatic disease. And they followed them over time, and they asked on their biopsy specimens, could this cell cycle prediction score kind of break apart these curves and tell us who's going to do bad and who's going to do good? And they did. They showed these guys with scores over 2 did much worse than these guys with scores less than 2. And it was very reproducible. But the issue is, this is not a very informative test in low-risk men. It's being marketed for low-risk men for decision-making, but it's not very informative for low-risk men. Because it turns out that even though the curves break apart when scores are greater than 2, almost no man with low-risk disease was in these two categories. These were all guys that we would have treated in this anyways, because we knew they were going to do bad based on just their clinical data. And in fact, if you look over here, this looks at the hazard ratio for having a high score of the test. For men with Gleason score less than 7, where we kind of don't know if they should be treated or not, the test wasn't helpful with a hazard ratio of about 1 and wide overlapping confidence intervals. So this test may be helpful to tell you that your high-grade disease is definitely going to do bad, but it doesn't seem to be that informative for low-risk men. And maybe that's not very surprising, because if you look at Ki67, which has been around for a much longer time, it's a protein-based marker of cell proliferation. What you see is that if the Ki67 staining is high, now this is a survival plot, so these curves are worse than these curves. If Ki67 is high, then these guys do worse. But there was no man with low-risk disease that had a high Ki67 score, and where it was informative is in men with Gleason 7 and 8 disease. So maybe it will help tell you how much treatment a guy with who you're going to treat anyways had, but it doesn't really tell you that a guy with low-risk disease is protected. How about PTEN, that we said was like a hub for telling us when localized disease is going to become aggressive? This is the same cohort of men. It's a transatlantic prostate group that these British guys that they were just following. And what you see over here on the right in these survival curves is that if PTEN was present, then and you had low-risk disease, you did pretty well. If you lost PTEN and you had low-risk disease, you did just as bad as people who had high-risk disease. And because high-risk disease, these guys can lose PTEN or alter the PI3 kinase pathway in a different way, it didn't matter if you had it or lost it, they all did bad. And so if we look at those same hazard ratios here in the middle, you can now see for low-risk disease, Gleason less than 7, if you lost PTEN, was it a big deal? Yes. Now you're at 8-fold greater risk of death from prostate cancer if you're untreated. And if we look at, in a series from Hopkins, if we look at people who get upgraded, there's a 3-fold increase in the chance that you'll be upgraded to prostatectomy. So I think that this test, looking at PTEN loss, is informative in low-risk men. It's not lost in many men, 3 to 18% it's lost in. But if I have a patient with low-grade cancer, has no PTEN staining, I get very worried that that man is going to have progression of their disease and needs treatment. There's two other tests that have looked at not just one single gene or that affects prostate cancer biology, but rather groups of genes. One that's available now for ordering is the Oncotype DX that's made by Genomic Health. This looks at 17 genes involved in different areas of prostate cancer biology or cancer biology, and it's been shown that if you have a higher score on this Oncotype DX prostate, that you essentially have more risk of being upgraded, meaning having higher grade tumors or higher stage tumors. And this might be helpful. You have about a twofold increased risk if you have these scores, but very few men in their study that were low risk also had this 20-point rise that would make it significant. And so I wonder how this test is going to do compared to something like PTEN, which a lot of these genes overlap with in those pathways. And is it going to be a cost-effectiveness thing? You know, a $50 immunohistochemistry versus a few $1,000 test like this. Another test that has not been approved yet, is not CLIA certified yet, but is emerging, is called ProMark by Metamark. This again looks at a panel of genes. Originally they were looking at PTEN, SMAD4, cyclin D, and SPP1, and if you had lost those genes, you did worse, the red curve, than if you would in the green curve. They've now, because of patent things for PTEN, they've switched to looking at surrogates, which is this phospho-S6 and phospho-PRAS40, and the test looks like it's going to perform pretty well. And again, I don't know if cost is going to be an issue here as well, and I'm not sure how much I'm going to use the test till it's validated if I have a cheaper option available. So now let's talk a little bit about local treatment. So if you have diagnosis, your urologist tells you, or whoever tells you that you need treatment, you know, can we improve local therapy to make it so that your treatment is less morbid, meaning you have less side effects, and maybe that's one of the paths forward. And I think before we get into that, we can just talk about surgery, because we're going to talk about radiation or proton beam for the prostate later. The prostate lives in this high rent district. The sphincter is here, that controls urination, the neurovascular bundles are here, and not only does the sphincter control urination, but the attachments of the prostate, to the pubis may also have a role, and the general structure of the pelvic floor may have a role. And so after removal, incontinence can happen, usually transient, but it can happen and be troublesome in some cases, and loss of erectile function can happen as well, and in many cases it will not recover. In some cases, particularly in younger men with perfect function, they can recover, but often not to the same level. And I think when we think about prostatectomy, and what I'll focus on for this talk is, there's been the emergence of robotic prostatectomy, and we'll talk about open and robotic prostatectomy and where surgery is. So for open prostatectomy, just to review a little bit, it is a disease, it's a surgery that is outside of the abdominal cavity. So it's an extraperitoneal surgery. The peritoneum ends there. That's where all the guts are. And we do our operating down here in the space of Retzius, which is outside of the abdominal cavity, so nothing to do with the bowels. We basically dissect the prostate free from these neurovascular bundles, preserve the sphincter, and then attach things back together. That procedure was described by Dr. Walsh and then popularized and disseminated when done at expert centers. And in disclaimer, I do both open and robotic surgery. In done at expert centers, the hospital stay is on average less than 2 days. Blood loss is fairly controllable now, about 500 cc's. Transfusion rates very low. Return to continence and erectile function in people who are good functioning before, particularly younger men, is very high. But robotic surgery came along as well. Robotic surgery, you put these ports in, and in most cases, it's intraperitoneal. So you invade the abdominal cavity, and then you have this view here, where you're looking at, this is the peritoneum, here's the guts area, and you have to cut the peritoneum and drop the bladder down, so you can now see the prostate, and then do the surgery the same way as the open prostatectomy. And this does have less blood loss because the insufflation of the abdomen decreases venous bleeding. So I would say it's 500 cc's in expert hands for an open prostatectomy. It may be closer to 100, 150 cc's for a robotic prostatectomy. And once they started to disseminate robotic prostatectomy, it really took off. So it started in around early 2000s, and then over time we saw this logarithmic increase in the amount of robotic prostatectomy. So that today, the majority of prostatectomies are done in robotic fashion. And this happened actually in the absence of any evidence. So why did it happen? Was it because it was so much better? Well, probably most of it had to do with direct patient marketing, so marketing directly to the patients, and then a change in the culture of medicine where hospitals were competing for basically patient dollars, and they were getting robots to say we had the next best thing. And is there any evidence that, now that robotics have disseminated, where in 2008, 2009, most people were beyond their learning curves, maybe robotics is actually better, and that's why it was adopted and not these cynical reasons. And so they looked at that recently. There was a publication in the Journal of Clinical Oncology that looked at SEER Medicare data, so it's older men, 65 and plus, in the post-dissemination era. And what they found is that robotic surgery, compared to open surgery, had statistically significant more genitourinary and miscellaneous medical complications than open surgery. Open surgery had a higher risk of blood loss and transfusion and an increased length of stay, and that was significant too. There was no difference in the need for additional cancer treatments. So cancer cure rates are basically the same, and robotic surgery, of course, is more expensive, about $1,500 per patient. So if you then ask, well, how about that didn't look at the functional outcomes? Maybe the sexual function and the continence is going to be much better with robotic surgery. And so these images parallel things we've seen at Hopkins. Just to be non-biased, I asked Dr. Klein, who's the head of the Cleveland Clinic, to give me his data, because they did also high-volume robotic and high-volume open surgery, and tell us, which one is better in their data. And in their data, with, basically thousands and thousands of cases, if you look at return to continence or you look at return to sexual function, it's essentially the same for open or robotic prostatectomy with no significant difference between the two. So, for me, I do both. And the reason I do both is because as a young guy who does prostate cancer, and because of, I feel like I had to offer everything, and the patients will come in asking for robotic, et cetera. But my perspective, doing both open and robotic surgery and having those tools in my toolbox is the following. What favors robotic surgery? If I have serious bleeding concerns, the patient's a Jehovah's Witness, they have need for continual baby aspirin throughout the procedure because of stents perhaps, or some other bleeding diathesis, I favor a robotic approach. There is less blood loss. If they've had a previous laparoscopic hernia repair, particularly in the early era when they were doing that, they used to put a large piece of mesh over that space of retzius that I'm going to operate in. That causes serious adhesions, and I highly favor robotic surgery in that case. What favors open surgery? If they've had previous intra-abdominal surgery, I favor open prostatectomy. My patients who've had colectomies or ruptured appendixes, I favor that. If they have very high-risk disease that we're seeing more commonly, Gleason 9, 10, possible even though the imaging doesn't show lymph node involvement, and I want to do the best lymph node dissection and get around the bulk of disease, I prefer open. If the patient is very obese, for the robotic surgery, they have to be in Trendelenburg with their head down. It can be difficult to ventilate those patients, and open surgery does not require that. So I prefer open. Similarly, if the patient can't tolerate general anesthesia and needs spinal anesthesia, I prefer open. And also for me, very large prostates, getting up to 100 grams and above, I think the working space is more limited with the robot. Degrees of freedom are more limited, and so I prefer open. But these are the minority of patients. I would say that most of the time, I tell the patient, I'd basically tell them about both and ask them whatever they want to do, because the procedures are right now fairly equivalent. So has robotic surgery done anything for urology in terms of moving the field forward? No, but it maybe gives us the potential to move the field forward, because there's some things you can maybe do with the robot that are not as easily done open. I'm just going to show a couple things on the horizon that haven't really, borne out as having big benefit, but they're there. One is this. They were saying we can maybe augment the repair of the pelvic floor to help early continence, and because you can sew deep in the pelvis, maybe a little bit easier with the robot, you're able to kind of bunch up everything after surgery when you bring everything together, and that may cause earlier return of continence. So that's interesting. The robot makes that a little bit easier. The second is they reported a couple years ago doing a completely intrafascial removal of the prostate. So stay out of the space of retzius, don't affect any of those attachments to the bladder, and just come in and through the pouch of Douglas, take out the prostate and hook things back together. That's similar to a perineal prostatectomy, and it's kind of neat to watch them do that, but it has the same cancer control issues that may not be as good as a perineal prostatectomy did. But this is only able to do through the robot. And then this is doing a lymph node dissection using a fluorescent dye that you can inject in the prostate, it goes to the lymph nodes, and then you can basically see where the first lymph nodes are. And again, that's technology that's easier done with cameras in a dark space laparoscopically. None of these really have benefited the field, but they show the potential for finding technologies that will actually benefit down the road. So what's our summary? Prostate cancer is a prevalent and sometimes lethal disease, but it's a disease spectrum, and about half the disease that's diagnosed does not require immediate treatment. Our understanding of prostate cancer is increasing, both with these randomized controlled studies, but also with the molecular biology of the disease, and PTEN loss appears to be an important factor in localized early prostate cancer. There are tests that are developed that may make prostate cancer screening better. I think the Prostate Health Index is one of those tests, and it's been FDA approved for this purpose. There's also tests that have not been FDA approved, but they can help with decision-making after diagnosis. I think that the ones that look at biological characteristics of the disease, like PTEN testing, look like they're going to be better for the decisions we have to make than looking at cell cycle features and progression. Finally, surgical technologies and techniques have evolved since Walsh first described it in 1980. The adoption of the robot was really driven more by marketing than it was by evidence. There's an unclear, meaningful clinical benefit for the robot. There's a clear cost detriment to the robot, but there's some subsets of patients that may be better from one way or another. Robotic surgery, however, may allow adoption of newer technologies, and so that's interesting. And overwhelmingly, what the data does say, and I didn't talk much about this, but it does say that, for prostatectomy, it's a 1 to 2 day hospital stay. The catheter can come out anywhere you want. It is something worth going to an expert center. So and there's probably one in each area. I'm sure there's one in this system too. And going to someone who does it a lot because they're familiar with the pathway and outcomes, and they'll do a good job. And that's it. I'll take any questions if you have time.
If the problem is that the disease runs in the family, what tests or what procedures do you recommend? My brother died at 76. His 60-year-old son has had a prostatectomy, and his 59-year-old son is suffering from some problem now. For me, what test should I have?
Yes, so there's a couple of things. One, if there's a strong family history, then, and yours definitely have a family history of lethal prostate cancer, then those are the men that I tell them they should start getting screened at 40. And so say we just had PSA. If you have a PSA at 40 and the number is under 1, then that man likely, despite family history, does not need to have screening again until they're 45, and then not again until they're 50. But if it's over 1, then you should have a strong suspicion, continue to do PSA screening every year, and if you see that the velocity of the PSA is going up, that man should probably get a biopsy. In the future, what's on the horizon, there are a couple genes that appear to be important for genetic prostate cancer. HOXB13 is maybe among the highest of them. But it's very unclear if routine testing for mutations in HOXB13 will do anything. And there's been different attempts at looking at what's called SNPs, single nucleotide polymorphisms, to see if they can categorize who might be at risk. But actually, those tests don't modify your risk as much as if your PSA is less than or greater than 1 at age 40. So I would say for you, obviously, I don't know how old you are. You're probably a little bit over 40.
I'm 18 now.
But so you should. But for your kids and family, you have a strong family history. They should start screening earlier, at age 40.
Thank you.
Sure.
That was a fantastic talk. One question. I'm sorry. One question that popped in my mind. Normally, we think of robotic and open prostatectomies, and I was a little shocked. I was always thinking that robotic was dramatically better. You had one slide that suggested that robotic surgery was more expensive itself, but the length of stay was also less. Could you comment on how much of a shorter length of stay? Because I do know that once you get to about $1,400, that's still probably less than your hospital room cost.
In the SEER data, the difference was less than a day, and then the reason they were and I'll talk about our data at expert centers like us and the Cleveland Clinic. For us, our length of stay for open is actually less than robotic. Our length of stay for open is 1.2 days, and for robotic it's 1.8 days. Cleveland Clinic, the same thing. The one thing that robotic surgery did that was great for the field is it pushed the open surgeons to get off their laurels and start looking at a pathway towards what is the best way to get people to recover and out of the hospital. And it really did the movement of taking what used to be a 5-day pathway down to a 3-day pathway, down to a 1-day pathway, because the robotic surgeries, in an effort to show that their way was better, were getting people ambulating earlier, we're getting them not on narcotics earlier, using things like Tylenol IV and Toradol, et cetera. And so, answer to your specific question, the difference was small. Even though it was significant, it was small, and that's why the cost was benefited. In expert centers, there's virtually no difference. In fact, I would say almost 100% of people can be discharged on day one, usually early in the day on day one, and be fine. And then the second part of it is one big change with robotics has been development of a pathway for recovery, and I think that's been a great thing, even though it's tangential. Ma'am.
Thank you very much for your talk. It was great. Thank you for coming.
Thank you.
So one question that I have for you is whether you do PTEN immunohistochemical staining routinely on your prostate cancer specimen?
So we have just finished validating it at our hospital, and I am now doing it routinely because our hospital charge when we do it in-house is so low. It's basically $50. And so I've started to do it routinely at our hospital, and by just recently I mean last month. The data's been out for longer than that, but it takes a lot to get it from you did a research study to actually we're going to be using this on patients. I think it's the one test that routinely, could benefit men, and the question is, how much are different areas going to commercialize it? So the Boswick Labs, for example, has a PTEN test. It's called ProstaVision. I don't know which antibody they use and how much has been optimized. They haven't published that, and I don't know what their price point is. So for most of my patients, I tell them, you may have a $50 charge for this PTEN test, and they're fine with it. Once the number gets to 500 or 1,000, particularly when people's nowadays with reform, the amount you have to pay before you start your insurance for taking over has become much higher. Then they start to wonder, like, well, how much am I going to benefit? And you say, well, if you're low risk, which is the 50% chance, then there's, somewhere between around 5% that you'll benefit from knowing this, and then they may say, the cost is too much. So, but your actual question, I do it routinely, and I think I would recommend it as a test, and I'm hoping that it'll come out there just like every other immunohistochemistry test, which would be at a cheap level that people can look at.
So do you think that's going to be part of the pathology report? It'll be Gleason grade?
I think so. I think that soon what you're going to see is Gleason grade, and then we haven't come to a consensus, but I think you're going to see PTEN and then also ERG. Now, I didn't talk too much about Tempris-ERG fusions. These are like the first solid tumor translocation to be really well described is this translocation between the Tempris and ERG, which ERG is an oncogene. It happens in 50% of prostate cancers. It doesn't really tell you if the cancer is going to be more aggressive or not, but it turns out that people with different combinations of PTEN and ERG, meaning like particularly PTEN loss with intact ERG, may do more poorly. And I think because these tests can be done by immunohistochemistry, can be done cheaply, they'll be seen at least as often as we see the triple stains. I don't know if you're a pathologist or not, but like we do the triple stain with Amicar and stuff like that, at least as often as that. And I think clinically that they're excellent. But I can tell you, even among my faculty that don't do prostate cancer for a living and don't have labs, they've asked me to give them a talk about PTEN because it's really just emerging. So this is the purpose of the conference. It's like a new thing that's emerging.
Great, thank you.
Thank you.
I'm going to ask another question on my ignorance. As a radiation oncologist, I often don't manage expectant observation. And I know, however, that there is some controversy in how expectant observation is managed for these very low-risk patients. Some people get PSAs every 3 months, others once a year. Some people repeat biopsies every year or two. I was wondering what the Johns Hopkins pathway is for expectant observation and what it entails.
Thank you. It's a great question. So we do a couple things, and I'll talk about our original pathway, and then I'll talk about how we've modified it. Our original pathway was to do PSA every 6 months with a rectal exam, and then a prostate biopsy every year. And I did a study with Dr. Carter several years ago looking to see if PSA alone could tell you whether or not you should have a biopsy. And it appeared that it really couldn't. Only in the minority of men would it be informative, so you had to do a biopsy to catch everything. We've gotten a little bit more relaxed with the biopsies in the last couple of years for two reasons. One, more data came out from the watchful waiting trials telling us that older men may be safer. Two was MRI came along. And so what we do now, so multi-parametric MRI, which is still also emerging, I think that the technique is excellent. It's probably the best way of imaging the localized prostate cancer. However, not everywhere can run the protocol well, and not everywhere has a radiologist who just does that and interprets it well. But, we're lucky enough that we do it very well. And it does give us a sense for the landscape within the prostate. There's a grading score that they use that mimics breast. It's a PIRADS grading score, and when the radiologist gives it a score of 4 or 5, they say this guy may have significant cancer. If they say 1 or 2, the guy usually doesn't have very significant cancer. And so what we do is that initial biopsy, let the inflammation go away, and then we do a prostate MRI to see if there's a lesion that we may have missed or an understaged the man. If there's a lesion we may have missed, we actually then will biopsy it with what's called a UroNav, which is an MRI-detected biopsy thing. Once they've gotten through that, now we feel they've been completely staged, and we're really following them safely. We'll still do PSAs every 6 months. We stopped doing the DREs as routinely, the rectal exams as routinely, and then if at a year, if they've had negative MRI and they had very low risk features, meaning just a couple cores positive, we will often not do a biopsy at a year. We'll do it at the next year, and we will only reserve the yearly biopsies for patients who've had more high-risk features, like their PIRAD score was 3, or they had multiple cores involved. So we've just started to change things, and I would say on average my patients are now getting biopsied every other year. We've just started to change things. We've just started changing them in the last couple of years, mainly because of MRI has helped us, and I'm hoping that as more years pass, we'll publish that data as well. I think that the routine for most urologists, San Francisco has a large surveillance population, is to do the biopsies more so every 1 to 2 years, as opposed to doing them every year. I think we were so worried that we were being over-aggressive. It's unclear if, there's a corollary, it's unclear, some of these molecular tests, because the cancer is evolving, it's unclear whether knowing the biological potential of a cancer has low biological potential at one time point, when is it going to become worse? It's unclear if they can make you safe from biopsies forever, which is the second problem with these expensive tests, because if you have to order it every year or 2, that's multiple thousands a year. And the same thing is true for biopsy, frankly. Thank you.
Any questions? Thank you very much.
Thank you. Thank you.